laboratory medicine provides about 70 to 80% of the resultant information that medicine uses in investigating and treating patients, and there's about 4% of our expenditure is in this area. Now, in the era that we're moving towards of predictive, personalised medicine, where we are dependent on biomarkers enabling the identification of individualisation of therapy, which we expect to be a much more economic way and a better way clinically for patients to be diagnosed and monitored, then there has to be validation of the biomarkers to ensure that we have the right markers. Now, because the difficulty is there are many, many markers out there which have been identified over the many studies that have been done, but very few in use. And the reason is that there's a lack of demonstration of clinical utility. Clinical utility meaning that you can identify a patient with a particular predisposition reliably without misidentifying somebody who does not have this predisposition, the consequence being, of course, that you could cause them therapeutic and diagnostic problems, which of course we do not want to do. The problem with biomarker studies is that yes, you need clinical utility, but to demonstrate clinical utility means population studies. Population studies cost money, and to have the appropriate studies we need, I think the clinicians understand this, but I think we need the politicians to understand the fact that we need appropriate funding to provide individualised patient investigations to enable their better diagnosis and therapy. And it's for this reason that my organisation, the European Federation for Clinical Chemistry and Laboratory Medicine, we call ourselves EFLM for short, has signed a Memorandum of Understanding with EPMA in the European Parliament yesterday evening, which demonstrates our recognition of why we should work together, and also the symbolism of the fact that politicians need to step forward and help us to address these issues.